Welcome to the Differential-Driven lung exam. First, we'll review some key lung exam maneuvers and some pathologies that correlate with those, and then we'll practice applying these findings to some cases. The schemata that we'll be using during this presentation is in the center of the screen. You can see that white represents airspace, gray represents lung parenchyma, and this dark gray on the edge represents the pleural space, which is a potential space. On the bottom, you can see the key. Red will represent inflammation, orange, mucus, green, purulence, blue, transudate, and lilac, increased air. So on the lung exam, there are two major actions that you're going to perform. You're going to auscultate and you're going to percuss. On auscultation, there are two major pathologies that you're listening for beyond just normal lung sounds. The first is wheezes, and these represent a lower airway obstruction. An upper airway obstruction is represented on exam by stridor, which is usually in the inspiratory phase. Wheezes are caused by many pathologies, but the two we wanted to cover here are asthma and bronchitis. In asthma, it is mainly airway inflammation from airway remodeling and airway smooth muscle contraction that causes the lower airway obstruction. In bronchitis, whether it's acute from an infectious cause like an upper respiratory infection or chronic bronchitis, there's a combination of inflammation and mucus production. And you can see that it's the combination of these two that results in a lower airway obstruction and causing a wheeze. The second major pathology that you're listening for are crackles. And another commonly used word is rales or rales. And these words are actually synonymous. Rales or rales is more commonly used in British literature, and the word itself comes from a French word for rattle. If you look at the word crackles, you can actually see the letters R-A-L-E-S inside of it, so you can remember that crackles are synonymous with rales. Crackles are caused by pathology at the alveolar level, and there's two major theories of what actually causes the crackle sound. The first idea is that crackles result from alveoli popping open during inspiration, whether due to fibrotic tissue surrounding the alveoli or edematous lung parenchyma or boggy parenchyma. The other theory is that during inspiration, air is bubbling through some sort of secretion or fluid in the alveolar lung space. Here are four main pathologies that can cause crackles on exam. The timings some are well understood and some are less well understood, such as early crackles in chronic bronchitis, but all are characteristic. You can see with chronic bronchitis and pneumonia, either some mucus secretions dripping down from the swollen airways or purulence filling the alveolar space can result in air bubbling through some sort of secretion on inspiration. So that's what's causing the crackle. Then with fibrosis or interstitial edema, it's instead either really scarred down fibrotic lung tissue surrounding the alveoli that pop open during inspiration, or with interstitial edema, swollen or edematous lung parenchyma popping open during inspiration. Then over to percussion. Beyond just normal percussion, you can either have increased percussion or hyperresonance, or dullness to percussion. Dullness to percussion represents an increased density in the thoracic cavity. This increased density can be either in the airspace, so some sort of increased density filling the normal air. It can be in the parenchyma, or it can be in the pleural space, the potential space. So here are some pathologies that could be. A consolidation, whether that's a pneumonia like we saw over here, or it's frank fluid or blood as in pulmonary hemorrhage. You can also have increased density in that pleural space with a pleural effusion. You have fluid where there's normally nothing. Or in atelectasis, from whatever etiology causes it, you have a collapse of that normal airway. So you lose the air in your thoracic cavity and you just have collapsed parenchyma. So those are all increased density states. On the flip side, you can have hyperresonance if you instead have decreased density in your thoracic cavity. And the only way you can have decreased density in here is to have more air. And the air can either be in the normal airspace because of destruction of normal lung parenchyma and emphysema, or you have air in the normal potential space of the pleural space, as in a pneumothorax. And you can have decreased breath sounds on any of these pathologies on the right-hand side. And that's because decreased breath sounds can be caused by two major pathologies. One of them is just poor movement of air through the normal lung space, such as in consolidation or atelectasis or emphysema. You just have disordered movement through that normal airspace. Or because you have an insulation effect and an increased distance between the normal sound-transmitting lung parenchyma and the chest wall where you're auscultating. So that can be either from a pleural effusion or pneumothorax. There's some sort of something in that pleural space that's not supposed to normally be there, causing insulation. But I wanted to circle back to consolidation versus pleural effusion, or really any sort of exam finding where you're going to have dullness to percussion. And this is a common clinical scenario to run into. So are there any ways that we can tell the difference between a consolidation and a pleural effusion on exam? Are there any extra maneuvers that we can do? And to really understand this, we have to take a step back and understand how sound that's created in the vocal cords and the larynx travels through normal lung parenchyma to reach the chest wall while we're listening with a stethoscope. And this graph demonstrates that. On the left axis, you can see percentage transmission of sound to the chest wall. And you can see that normal lung tissue does a really good job of transmitting low-pitched sounds or sounds below 300 hertz. These are things like speaking. This is why you can hear your patient talking when you're trying to auscultate their normal vesicular breath sounds, as well as tactile fremitus. However, normal lung parenchyma does not do a good job of transmitting high-pitched sounds or sounds over 300 hertz. These are sounds like bronchial breath sounds, the tubular, harsh sounds of the upper airway, as well as egophony, bronchophony, and whispered pectoriloquy. And this is why you don't hear either of these things normally when you're listening to a patient with healthy lungs. So why is this clinically relevant? We return to the two etiologies we're trying to differentiate between on dullness to percussion. In a consolidation, you have some sort of fluid filling the normal airspace, and because things of higher density transmit sound better, you'll have better transmission of low-pitched sounds or increased tactile fremitus on exam, as well as high-pitched sounds, so you'll have positive bronchial breath sounds, as well as egophony, bronchophony, and whispered pectoriloquy. Contrast that with a pleural effusion. Instead of the fluid inside the normal sound-transmitting lung parenchyma, like a consolidation, the fluid is in the pleural space and instead insulates that sound. So you have decreased sound transmission in the low pitch range, so decreased tactile fremitus, and equivocal findings in the high pitch range, but much lower than pneumonia. Now that we've reviewed this schemata, let's apply it to a few patient cases. Here's our first case. On auscultation, you appreciate that lung sound on the right lower base. And that sounds like a crackle, the red box for reference. Also on auscultation, you appreciate decreased breath sounds in that same area. So then you move on to percussion. You appreciate dullness to percussion again in that right lower lobe or that right lower lung space. So then you're thinking to yourself, there's still a couple things that could be going on. And I remember with dullness to percussion, I had some differentiating maneuvers I can perform. So you do this. You have the patient say E, and this is what you hear. And that was an example of positive egophony, the E to A sound in that right lower lung base again. You then appreciate this change. Those tubular breath sounds are bronchial breath sounds. And then when you perform tactile fremitus, you appreciate an increase in that, again, right lower lobe. So with those findings, you can narrow down that dullness to percussion to probably being a consolidation. And this patient likely has pneumonia. So just to review some of these maneuvers, on the bottom, you can see the likelihood ratios down here. Egophony and bronchial breath sounds have the strongest, though. Here's our second patient. On auscultation, you don't appreciate any wheezes or crackles, but you do appreciate decreased breath sounds in the right lower lung base. So you move on to percussion and you appreciate these findings. So again, some dullness to percussion in that right lower lobe. So again, we're back to this dullness to percussion, and we want to use our differentiating maneuvers to decide if it's a consolidation or a pleural effusion. And when you perform those, you actually have decreased vocal resonance. You don't have any pause and epigophony, bronchophony, things like that, and you have decreased tactile fremitus. So you're pretty sure that this is now a pleural effusion. And here on maneuvers at the bottom, you can see that these decreased breath sounds, diminished vocal resonance, and decreased tactile fremitus all have really strong likelihood ratios for an effusion. Here's our third patient. On auscultation, you hear this. Diffuse wheezes throughout their lung fields. And then, actually superimposed, you also appreciated this sound. So that crunchy noise was crackles as well. So in both bilateral top to bottom lung fields, you appreciated diffuse wheezes and crackles. You think that those crackles might have been early in their timing, but maybe you're not sure. On exam, you also hear decreased breath sounds. On percussion, you appreciate this. And that was increased or hyperresonance diffusely throughout the lung fields. So in this combination of wheezes, crackles, decreased breath sounds, and hyperresonance, you're thinking this is going to be COPD. And the early inspiratory crackles have a phenomenal likelihood ratio of 14.6 for COPD. And the other findings also are helpful, hyperresonance and decreased breath sounds. In our last patient, on auscultation, you appreciate this. These represent crackles in the bilateral lung bases. You don't appreciate any decreased breath sounds, though. On percussion, you don't appreciate any changes. On the rest of your exam, you then appreciate a positive S3, some peripheral edema, and elevated JVP, and you diagnose this patient with congestive heart failure. And this has an asterisk because we're really trying to represent the interstitial edema phase of heart failure. The next slide shows an overview of how interstitial edema can progress to alveolar edema and a pleural effusion. But for interstitial edema, crackles are really your only pulmonary exam finding that you're going to have on exam. This slide briefly demonstrates the progression of left heart failure. You begin with increased pressure in the pulmonary veins, and this vascular congestion causes some interstitial edema directly surrounding the vascular bundle that surrounds the alveoli, and this is also known as boggy parenchyma. However, as heart failure progresses, you have continued fluid leakage into that interstitium, and this can't be compensated by lymphatic drainage anymore, so you can progress to frank alveolar edema, or a consolidation, or a pleural effusion. This concludes our video on the differential-driven lung exam.